Okay, I think we can start our conference. Ladies and gentlemen, dear colleagues, I'm happy to see you here, and our guests from Armenia and Switzerland. I'm glad to see you at our conference of innovative methods of disease of maxillofacial surgery. Today we have a very big program, and at first speaker will be our beautiful guest. She is a chief of company Stomus. She is a great doctor. She has a very interesting opportunity to show you how to be a good doctor, how to get a lot of research and about our future. Please, Елизавета Михайловна Черновол.
Thank you, Tamara. For me, it's also a great opportunity because every time I'm here, I feel myself as a student. It gives me a very nice feeling. And first of all, I would like to say thank you to my alma mater, St. Petersburg State Medical University, and of course to the Department of Foreign Languages, because the knowledge of medical English that I got in the university gave me possibility to get acquainted with so many well-known doctors all over the world and to become a member of International Dental Society. Can I please show the presentation, because I would like to boast a little bit. This year I was invited to the International Dentsply Sirona Congress in Berlin with more than 3,000 participants, with a lecture, networking in dentistry. I wanted to show nice pictures. We will wait.
Technical problems.
So here you see the photos from the Congress, and actually for me it was a big challenge, because to speak on the main podium before this big audience and to do it in foreign language is very difficult. And I think that all those who will make reports today, even if they won't win the first prize, nevertheless, they all are already champions. Please remember this. You are the best. And now I would like very briefly, because we are short in time, to share with you some small ideas from this presentation. First of all, if you want to grow professionally, you need to build your own professional network. Be open. Make friends. Don't hesitate to enter any cooperation and any collaboration. Don't think about profit from the very beginning. Profit will come later. It will come as new knowledge, new opportunities, probably new job, probably new referrals. Don't be afraid. Start making friends. Use social networks for professional communication, but do it in a smart way. Always think twice before you make some post or comment in the internet. Let your personal account advertise and not compromise you. And nevertheless, even in our era of digital technologies, never neglect face-to-face communication. If you come to a congress or hands-on course, immediately start communication with your colleagues. And at the end of the day, you will get knowledge both from the lecturer and from the audience. And what is also very important, a moment. Doesn't work. We'll try once again. What is also very important, always to be hunting for new information and new technologies. Can you help me with video, please? I don't understand what is the problem here. It's a small video, how your professional life should look like. You should be always looking for something new. You should look for new medical technologies. For new materials. You should remain a student till the end of your life. And if you would like to be the best, you should learn a lot, and not only medicine. Nowadays, you should know business, you should know law, you should learn marketing and psychology. You should know how to communicate with your patients, how to equip the clinic. And if you are always be hungry, always looking for new knowledge, you will be successful. And one last but not least idea. If you want really to be networked, you should not only take. You should give. You should give your colleagues knowledge, experience. You should give them your sympathy and your respect. And now I'm lucky because I can also demonstrate my great respect to my teachers and personally to Nelly Gennadievna, because she was among the people who taught me professional language of networking. Thank you. And I wish you nice conference and fantastic professional life.
Thank you very much. It was brilliant. Let me to introduce you our jury. Today we have an opportunity to listen Елизавета Михайловна Черновол. Also, thank you for your coming, Nelly Gennadievna Bagrova. You can see our good doctors who grow up behind our eyes, very great professional now, Danet Pazi, and our doctor Artur Ismailov. Okay, and the second word will be our guests. It's the first time when our university have an opportunity to connect with Switzerland, and our colleagues Julie Smirnova and Joël Lenguem will tell us about invited classroom model in medical education. Are you ready? Помогите. Hi, are you ready?
Do you hear me? Hello?
Hello.
Hello? Do you hear me? Hello?
Do you hear
We
Julia?
hear you, but we haven't seen you yet.
Yes, I'm hearing you, but are you hearing me?
Презентация.
Алло, алло.
Hi.
Алло, Дмитрий, меня слышно?
Да,
Да,
we
мы
hear
вас
you.
слышим и видим.
Хорошо.
Julie, you can start your topic, your presentation.
Okay. So we'll talk with my colleague Joël Liengma. We'll speak about our project with
I'm
the
sorry,
High
one
School of
second,
Medicine
please. We
in
have some
Fribourg,
technical
the
problems.
project on inverted class. So the subject is pedagogical and not about maxillofacial surgery, but I'm sure that you could that it could be interesting to you. So now we know that the student activity and the statement and achievement of learning goals by oneself increase significantly the effectiveness of personal and professional training or learning. There are many separate new trends in didactics that include self-directed learning, or also another word, self-regulated learning. And it appears in the middle of the 20th century in Europe and in America. Among the theorists of self-directed learning, we can name Mr. Hiemstra, Brockett, Candy, Knowles, and so on. Many of them are Americans, Anglo-Saxon scientists. Now we know that a part of employers require from potential employees not only a diploma on higher education, but also certificates of training and specialization in very specific narrow areas. And the definition of this area and the rhythm of learning is completely the zone of responsibility of the employee. So it refers to self-directed learning, actually. And the flipped class or inverted class technology creates the possibility of organizing the self-directed learning in the frame of classical formal education, which is very important. So the educational content and the competences in it are organized in such a way that most of the time, each student works at his own pace, at his own rhythm, but he can use classic methods of learning. And flipped class is a focused process of organizing students' activity. Sometimes we also call it mixed learning, so in which the learning process is uses all possible information resources, including the internet, educational platforms, etc. flipped class or inverted class is called so because it disrupts the usual sequence in which the learning content is first explained and studied in the classroom and then at home when performing extracurricular independent work. So there are more or less 4 stages. At the first stage, which takes place at least a week before the lesson, a week before the classroom, we set learning objectives together, so targets together with the teacher. Students receive questionnaires, links to texts, articles, monographs, books, etc. Also video clips, it could be materials on YouTube, whatever. And then they should study all this at home. Also, most of the material is located in e-learning environment. For example, the platforms such as Moodle. I don't know if it's used in Russia, but here it's very largely used, the Moodle platform. So the second stage, also extracurricular, so not at the university. Students study the necessary material, answer the questions, and perform tests. All materials are prepared individually or in microgroups, and then it's placed on an electronic platform, educational platform, so for example Moodle, so that both the teacher and the other students can go and familiarize themselves with the material. So the students are actively involved in the process, and the teachers can also adjust and redirect the students. So the third stage of the inverted class takes place in classroom, and all the work that was began at home continues so in class, and the obligatory condition is that it could be a productive form of the lesson. For example, work in microgroups, some project activities, case studies or case analysis, discussion, etc. So active form of work. And the fourth stage, which is the final one, is the also extracurricular. So it's a reflection on the content, the further work on it, etc. So it can be done independently by each of the students. So our project with the Fribourg High Medicine School in the form of invert class will be presented by Joël Liengme, who took personally part in this project. He could share the experience with you more in details, and also show you some photos that could give you the image of how it was. So, Joël.
Okay. Hello, everybody. I'm here talking from Switzerland. So with the Institute Pavlov and the School of Osteopathy of High Medical School in Fribourg, Switzerland, we built a two-day pedagogical formation about. Sorry, where is my first page? We build a module of formation of education, of pedagogical education about learning patient-centered communication and shared decision making. Because we've seen that a lot of scientific publications shows that there is a decline of empathy by medical students from the 3rd or the 4th year of studying. Here we are not talking about emotional empathy, but more about cognitive empathy or clinical empathy. And because of this project had been created between Russia and Switzerland, we wanted our students to get skills in active communication because like that they can skills to help them understand each other. So we built these 2-day modules formations about shared decision making and patient-centered communication. Please. And we made it in four steps. But first I have to tell about why the pictures are changing, please.
Some problems?
Can you hear me?
Some problems?
Yes. Yes, because we wanted some technological resources for this project between Russia and Switzerland. But I have to tell you that this project ACTCOM can exist without technology. But there, because we were between Russia and Switzerland, we used Skype communication to get the students communicated with each other. And so that's why we used a bit of technology. The first steps of ACTCOM is the active learning, where all the participants, the students, can go receive a link, an internet link. This link is documents on the Google Drive. And with this link, they can get all the pedagogical instruments, the material. They can teach, read, teach. There are also some videos. And they must answer to some questions that we ask them. That's the first step, the active learning. The second step of the day was that every groups, the first day you have here the lesson objective. With the first group learned on the Google Drive the principles of clinical conversation. The second group learned some components of active listening. The third group learned how to read and use nonverbal cues to steer communication. And the fourth group learned how to use active empathy. Then all of these groups came to the other for the step 2 to explain to the other what they have just learned. Like this, every group can learn of what the other has brought. Then of the day there was the third step, that was a simulation of a clinical situation. The point where every student received a clinical vignette. It's a small text explaining a patient's situation with its pain and so on, but not all informations are on these clinical vignettes, and so the students must go and reach into their fresh knowledge to discover the underlying situation given by the vignettes. They must interview a simulated patient, like in a clinical situation, like when we are doing anamnese and clinical exam, and with active communication, with non-verbal cues and so on, and patient-centered communication, they must discover all the underlying situations given by this patient, these simulated patients, and by the situation. That was the biggest point of the day, because this point allows the students to get this transfer from knowledge, from theory to practice. This is the purpose of our ACTCOM toolbox. Yes, it's like a toolbox. The first purpose is the transfer from theory to practice. So we built 2 days of education about clinical empathy, active listening. I presented you the first day. There had been a second, also with the clinical vignettes, where the students could directly transfer from theory what they have just learned to practice. And that's how we built ACTCOM ACTCOM 2 days pedagogical box or pedagogical package. I must say that ACTCOM is a pilot study that we have to evaluate the validity and the efficiency of these projects, of this toolbox. And we must still evaluate it by measuring an eventual increase of level of clinical empathy by the students and by qualitatively evaluate the students' satisfactions with the questionnaire. That's the work that has to be done yet. I'm over with my presentation. If you understand everything, do you have questions? I can't hear you anymore.
Me neither.
We can hear you. Thank
Okay,
you very much.
now I can hear you.
Very interesting. Guys, maybe you have some questions from the auditory? They all shy to ask something. Do you like St. Petersburg? We know that you visit our university.
Mm-hmm. Yeah. And? I didn't understand.
We don't have any questions. Thank you for your report. I think for our students it was very interesting, and for the future education, they can use these knowledges. Thank you very much.
Yes, I must say that we are in an open education philosophy where we want to put material available for everybody, and that's the purpose of this ACTCOM toolbox. And we hope that this is efficiency to get the clinical empathy level by the students higher. Thank you for listening.
Thank you a lot. Спасибо.
Thank you, Joel and Julie. The second report from Armenia, from our maxillofacial surgeons, Anna Yurievna. Do you hear us? And
No.
hello. The report will be.
Mai rog să-ți răsumesc. Mă mecnațele.
The reporter will be Nahabat Idikaran. Yes, correct?
Yes, it's right. But about slide.
They will tell us about treatment of mesodermoid carcinoma.
Vargul 27-29 slide. We have to wait a few minutes because the presentation file we can't open it now, it's downloading.
Okay, we will wait you. It's okay. If you see our message, you can follow us on YouTube. Also, you can see all the conference. When they allow the presentation, guys, please don't be shy. You can ask questions, you can discuss, because after this topic we will listen our students and the young doctors, and who will be the most active and ask more questions. We'll have something special present for them.
Ez mikrofonları mı yanımda? Mi yanımda? Jo, İran savunca tek merak etmiyor. Siz ondan iyi.
I will give you a
Ne kalmak yok.
after conference. Okay.
Могу все вытворчить там, да?
Да, имам отвал.
Творческого процесса было реконструкция.
Да.
Yaptıracağım el çıkarmayın burada.
Mikrofonu bana.
Tamam.
Will ask.
Sorry,
Sorry, we have a question from auditory to Joel and Julie.
عندك معاطي
عندك معاطي كده
Gottungen Darlegungen
Sto sürmede çeyreğe
Hello everyone again. Can you hear me? Yes? Okay. My name is Nabe Dirazarian and I'm passing my second year of residency in maxillofacial surgery department in Mikaelian Surgical Institute, and head of department is Artur Papikyan. As you could understand, we will speak about mucoepidermoid carcinoma of a palate, and we will have a case report. And salivary gland tumors comprise almost 5% of head and neck malignancies. The biological behavior of malignant salivary gland neoplasms can be used to classify these tumors as low, intermediate and high-grade malignancies. In general, the most commonly encountered tumor is the mucoepidermoid carcinoma that accounts up to 30% and 35% of parotid and minor salivary glands, and up to 20% of those involving submandibular gland. Mucoepidermoid carcinoma have been reported at a distant and atypical sites, including a breast, eustachian tube of ear, bronchi of lungs, and thyroid. Reports of mucoepidermoid carcinoma of the subglottis is not common, and women are more commonly affected than men, and the mean age at onset is in the 5th decade of their life. And the mucoepidermoid carcinoma is the most commonly disease for children salivary glands. The tumor usually forms as a fixed, painless, slowly growing swelling of widely varying duration that sometimes goes through a phase of accelerated growing immediately before clinical presentation. And the symptoms include dysphagia, otorrhea, trismus and tenderness, and mucoepidermoid carcinoma can resemble like vascular lesions or mucocellus, and this tumor can invade underlying bone. Mucoepidermoid carcinoma represented as a distinct type of a tumor, and it contains from 3 types of cells. squamous cells, mucous secreting cells, and intermediate cells with varying proportions. And mucoepidermoid carcinomas cell type classified histologically as low, intermediate, and high-grade types, and prognosis are different, and it depends from the site of tumor, from the stage of tumor, from the adequacy of the surgery, and 5-year survival rate ranges for high-grade tumors from 0 to 43%, for intermediate 63 to 92%, and for low-grade tumors from 92 to 100% survival rates. And mucoepidermoid carcinoma is a multifactorial disease, and there is not only one factor that can cause this pathology. There are three basic unhealthy things that can cause this pathology. It's radiation, viruses, for example, HIV virus, HPV virus, and chemical substances. And studies that had done in the Hiroshima and Nagasaki cities showed that the people who live there are related to a high risk group of salivary gland malignancies. Now I will start my case report. A patient, 62 years old male, presented to maxillofacial surgery department of Mikaelian Surgical Institute at 28th of October on 2018 with a 1-year history of painless growth on the right side of the palate. And the patient noticed ulceration of that part of palate, and the life history showed that the patient had been a smoker more than 25 years, and he smoked like 5-10 cigarettes in a day. And the extraoral examination showed submandibular palpable lymphatic nodes. They are mobile. The lymphatic nodes were mobile, single, and painless. And the other facial structures appeared normally. Intraoral examination showed ulceroproliferative growth, approximately 3.5 to 3.5 centimeter size on the right side of the palate. On the palpable, it was non-tender, firming consistency, and you can see that the surrounding mucosa is normal, appears normal, and there were no secondary changes. And we started to creating a treatment plan. And we did an incisional biopsy of the growth, and the histological conclusion was high-grade mucoepidermoid carcinoma. And we did a CT scan, and we did a sonography of the neck. Here you can see the CT scan and the sizes of the tumor. And we decided to do a modification of radical neck lymph node dissection and partial maxillectomy, the right side of maxillary bone. Here you can see the mark for incision. Now you can see perfectly the external uvular vein, which we tied with the sutures later. There is an internal uvular vein. We removed the first, second, third, fourth, and fifth lymphatic nodes, and we tied with the suture even the external carotid artery. We removed the submandibular salivary gland, and after we started the operation on the face. The incision line starts from the middle of the upper lip, then continues to the alar rim and then to the upper lateral cartilage until the medial canthus. And with the piezotome we remove the maxillary bone. Here is the piezotome. And we removed even the floor of the orbital bone, because as we know, this kind of tumors, operations on this kind of tumors, we have to remove even 1 centimeter or more normal tissue. And this time the normal tissue was the floor of the orbital bone. Then we repaired it with the titanium mesh screws, and we closed the wound. This is the post-operative picture after 2 months, and after rehabilitation that it passed, with the prosthodontics we make the obturator for this patient. And after rehabilitation, he did a 2-week adjuvant radiotherapy. This is the obturator. That's all. Thank you, and if you have some questions, I will talk to you.
Thank you very much. Great job. Thank you. Maybe now we have a question. It's a very great opportunity for you students have a question from surgeons. No? Nobody?
We removed only right side of maxillary bone, not bones. I said that we removed only one side.
The unilateral maxillectomy.
Out from vascular surgery.
We can't hear anything. Can you write your question on the chat, in the chat, if you have them? We are planning to do the second part of operation after 1 month. We are planning to do, yes, a reconstruction with autologous bone.
Thank you. You can join us our conference to the YouTube channel. Also, we try to make a connection in this connect, and we going next topic with our program. We have some changes. The second speaker will be Filip Siniavski with a multifactorial approach of different diagnosis of sarcoidosis and surgeon disease. You have, everybody have 7 minutes. Please get a time limit.
Dear conference participants, let me introduce the work dedicated to the work on differential diagnosis of Sjogren's disease and sarcoidosis. Sarcoidosis is systematic disease with unknown etiology, histologically manifested by the presence of non-caseous epithelioid granulomas in various organs. One of the options for the clinical manifestation of sarcoidosis is Hayford's syndrome, which appears to be a triad symptoms: anterior uveitis, parotitis, and facial nerve paralysis. The similarity of clinical pictures as well as a variety of manifestations determines complexity of differential diagnosis of these diseases. If sarcoidosis is suspected, patients first come to pulmonologists or tuberculosis doctors who use histomorphological studies for intrathoracic lymph nodes gained by broncho or mediastinoscopy, which is a complicated procedure and also requires special skills from the surgeon. Instead of this, biopsy of the parotid glands is minimally invasive and equally effective procedure, such as lymph nodes, even in the absence of clinical lesion of saliva glands. Let me introduce the clinical observance of patient suffered from sarcoidosis with saliva, lacrimal glands, and intrathoracic lymph nodes lesion. Patient admitted to the department of maxillofacial surgery of First Pavlov State Medical University of St. Petersburg with next complaints: a significant increase of both saliva glands, dry cough, dry mouth, a decrease of tear, and other. At the objective examination of general condition of the patient was satisfactory, clear consequences, pale skin, normal nostril. There was a significant increase both salivary glands due to external lobes, palpation with dense consistency, painless without fluctuation. During the massage of ducts of saliva glands, a moderate amount of clear saliva is secreted. Mucous oral cavity bright pink, dry tongue. As laboratory examinations, according to the data, paying attention at positive sample of Epstein-Barr virus, high titers of angiotensin transforming factor, circulating immune complexes, didymer, and normal situation with rheumatoid and antinuclear factor. In that X-ray X-ray we can see diffuse increase of both saliva glands, and combine CT of paranasal sinuses, we can see hyperplasia of mucal membranes of all of sinuses. And finally, histomorphological examination of small and parted saliva glands. At results we can see characterized by sarcoidosis, non-caseosis, epithelioid granulomas. As a sample in right upper corner, we see histological picture of Sjogren's syndrome. It characterized by lymphoepithelioid infiltration with tendency to penetrate in acini. Differential diagnosis of this patient requires doctors of other areas, and only work together we can verify that atypic sarcoidosis. And at last, refine the empowerment, but patients were not monitored by pulmonologists and not carry out the necessary control studies. At the moment, the patient had no complaints despite the lack of treatment. In conclusion, I would like to say that histomorphological examination of saliva glands at this situation play high role to difference diagnosis. Bibliography. Thank you for attention. Any questions?
Yes, I have a question. Please. Dear reporter, thanks for your presentation. And I have a question, because perhaps I missed this information in your reports, but whatsoever. What is the main and common symptom, the main sign of this disease our patients will suffer? The main symptom?
Main symptom is increase of saliva glands with xerostomia.
Increase, yes?
As a result, patient have bright right mucosa membrane, dry tone, it is main symptom. Thank you for question. Thank you.
Thank you very much. The second report from Bogdan Popov, please.
Well, good afternoon, dear colleagues, honored members of the jury. My name is Bogdan Popov. I'm the second year student of dental faculty. My science supervisors are Professor Solovyov Mikhail Mikhailovich and practitioner Alexander Popov. So the title of my work is the review of the results of the system approach using the data of the PSAF autodisabsation, diagnostics appliance in dental surgery, and urological patients in health facilities. And before I commence my presentation, I would like to share my ultimate gratitude for the occasion to present my work to you, and for the comprehension and for just brilliant reports I've just heard, and I will hear. So, as you know, nowadays it's completely obvious that we live in the era of new frontiers, of new global scientific changes, and especially in medicine, and particularly in dentistry. That's why we're here today. So regarding that alterations, an advent of brand new approach to a patient has occurred in the last years. And so this shift has been over from biomedical model to biopsychosocial model of approach to a patient. And of course, World Health Organization has entailed the definition of health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. Well, as our university is a breakground in science in the Russian Federation, it has designed and suggested a new methodic of penetration into the ontogenic image of disease. And this methodic is called psychosensory anatomical functional autodisabsation. The prototype of this methodic has been suggested by academician Luria, which declared, it is better to let the patient expound his feelings the way he wants to and is able to. Such a conduct of a doctor immediately establishes psychological compliance needed with the patient and builds trust in him. That's an indispensable condition for discovering and unraveling the ontogenic image of the disease. And of course, our university president hasn't stayed away and just said that in the principle of positive affection on the patient's psychological status lies the conception of ontogenic image of disease. And the first step of it is an express diagnostic of PSAF autodisabsation syndrome. In the USSR there was such a film as Have You Called for a Doctor, which starred Leonid Bronivoy in the role of professor, and that professor said such a distinguishing thing as, I'm completely sure every patient yearns for confessing to the doctor, as merely every patient, consciously or unconsciously, seeks for solace. So, what is autodisabsation? It is ontogenic disadaptation, from Greek autos itself or himself, genus, origin, Latin dis, that's an absence, adaptation, adjustment to conditions, and it is an integral significative of human adjustment dysfunction to internal or external conditions determined by subjective self-conception of psychological, somatic, physical, and socio-economical status. So PSAF is a key principle to penetrating into ontogenic image of disorder. It comprises four main classes, which are psychological cluster, sensory cluster, anatomical cluster, and functional cluster, and all that comprises PSAF, PSAF. So the purpose of my work was to test PSAF autodisabsation methodic of the system approach in studying dental surgery, urological and andrological groups of patients in different health facilities in the town overall. Object of my study was 70 outpatient first admission patients of dental surgery, urological and andrological groups. There were 44 women and 36 men, aged between 90 and 69 years. Methods of study comprise medical history collection in a classical way, written in papers of confidential voluntary informing by the patients in an edited and altered version of the key concept question which we ask every patient in our so-called self-methodics. It is from healthy and successful person to healthy and happy person. That was our changes in a design. Of course, physical, instrumental and laboratory examinations of patients, and it's undoubtedly patients were guaranteed for total anonymity as it's crucial in the urological patients. Results. Here you see the table which demonstrates the distribution of dental surgery patients regarding integral PCF or adaptation index. As you can obviously see, there were no any patients reaching the level of moderate, profound, high or extremely high levels of PSAF or adaptation. All of the dental surgery patients have unconvincing or below 60% PSAF or adaptation syndrome. And all of them, 33 patients, didn't gain any points after 28. Here you can see distribution of urological and andrological patients regarding integral PSAF or adaptation syndrome. And here you can see some different results from dental surgery patients, as urological patients have high and profound levels too. That indicates that urological patients tend to be more concerned about their health conditions and their results of the therapy. Yes, I have time, yeah. I'm just overing. And the structure of PSAF ADA. Letter A indicates dental surgery patients, letter B, urological patients, and you can see greater variety of symptoms and diseases urological patients has applied to a doctor. There is a structure of the psychological cluster of 32 urological and andrological patients. The most common and commonplace symptoms and things were socioeconomical problems, anxiety for relatives, anxiety for future, and infertilities. That was the main health problem and issue in our research concerning urological patients. Here is an example of a urological patient who has ecology, leisure accessibility, infertility, and small business development problems. That concern this patient, and that is a structure of PSAF or adaptation cluster of 30 years old surgery patients. Her integral PSAF index was 62. It's quite high. And as you can see, there are no any health problems and health issues and health symptoms, only socio-economical clusters, and that demonstrates the overall tendency. So, conclusion. Psychological cluster was dominating in both andrological, dental surgery and urological patients. That indicates that expressed method of PSAF or adaptation allows to identify prevalent cluster in different nosological groups of patients. The PSAF methodic could be employed in sociological studies, and PSAF methodic facilitates practitioner, a simple doctor, in outpatient admission to apply in practice the principle of biopsychosocial, patient-centered model to compile an individual approach to treatment and rehabilitation. So, many thanks for listening. Any questions? No questions? Thank you.
Thank you very much. The next speaker, German Kosic, about osteonecrosis from the drug. This is very interesting.
Okay. Hello, everyone. Dear members of the jury, dear colleagues, real and future doctors. Let me introduce myself. My name is German Kosic, and I'm the resident of the dentistry surgery of Pavlov, First St. Petersburg State Medical University. So the theme of my presentation is represented on the screen and sounds like solidexide as a drug of choice for prevention of medication-related osteonecrosis of the jaw. It is a well-known fact that American Association of Oral and Maxillofacial Surgeons created in 2014 a special position paper in which they represented at first new nosology called MRONJ, or medication-related osteonecrosis of the jaw. Until that time, these diseases were called under the name of the drugs which were carried out, for example, bisphosphonates-related osteonecrosis or denosumab-related osteonecrosis, etc. So, if you find any information in the science world on such databases as NCBI or Clinical Key, we'll find out that there is for about 5 theories of origin why osteonecrosis appears. They are imperfect bone metabolism, immune regulation, hereditary factor, some disorders in metabolism of osteoblasts, and circulatory disorders. So if our study was an attempt to protect the circulatory system from the exposure to one of these drugs that causes osteonecrosis. In this way, in our study, we pursued the following goal: to estimate the possibility of solidexide drug in prevention of development and decrease of osteonecrosis dimensions of zoledronic acid. First of all, we wanted to find out the normal reaction of the blood vessels under the application of special classical probe of acetylcholine. Then, after this, we checked the changes in model of MRONJ in the rats and searched for the opportunity of solidexide to restore blood flow. First of all, zoledronic acid is a amino bisphosphonate which has strong effect on the bone tissue. It affects on the osteoclasts. It stops its effect. So osteoclasts balance shifts to the side of the osteoblasts. In other words, to the modulation of bone tissue, not for its destroying. Got it. Okay. In this way, bisphosphonates such as zoledronic acid are used in such chronic diseases as chronic osteoporosis or malignancies, metastasis of malignancies into bone tissue. The second drug is solidexide. Solidexide is the anticoagulant. It has two effects: angioprotective and antithrombotic. It inhibits the formation of thrombin and throws out plasminogen. So it will be, in theory, it is a protection of blood vessels which can be destroyed by zoledronic acid. In our study, we used two methods of registrate blood velocity. It is a Doppler, it is a high frequency Dopplerograph, and laser flow meter. All in all, this method allows to estimate the blood flow rate at the level of mucous membrane and bone tissue together. 36 rats of lion Vister we used in our experiments. They were compared into 3 equal parts. The first group of control. Physiological solution was administered, chloride of natrium. The second group experienced zoledronic acid was administered for about 6 weeks. And the last one, it is experience group number 2. Zoledronic acid was administered for about 6 weeks, and from the 4th week, for prolongation of 3 weeks, solidexide was added to them. After the last administration of the drugs, tooth extraction of first left molar of mandible jawbone was carried out to initiate the osteonecrosis. Blood velocity was studied before and after extraction of the teeth in the classical acetylcholine probe. This probe is used in medicine to find out the vascular reactivity. During the first 2 minutes, blood velocity rises up, and by the 5th minute comes to the initial values. Of course, based on the result obtained, statistical data tables were compiled. Many parameters were taken in the account blood velocity, and we should know that it is the registration of 2 layers, histological layers. It is mucous membrane, periosteum, and bone tissue, two layers, mucous membrane and bone tissue together. These tables were created for ultrasonic and laser Doppler. We have a patent for invention of the method of determining the speed of blood flow of the red periodontal bone in the experiment. When we calculate the blood flow velocity of the bone tissue, it can be seen that with the introduction of zoledronic acid, the blood flow's velocity decreased up for about to 60% from normal. But while as with administration of solid oxide, it restores up to almost 90%. So the main idea of the experiment is to find out the blood velocity only in the bone tissue, because zoledronic acid effects, like all bisphosphonates drugs, they affects only on the bone tissue, not on mucous membrane and periosteum. Okay, about results. Application of acetylcholine stimulates the blood speed in the rat's periodontal, which has reached the maximum at the 2nd minute and returned to the initial values at 5 minutes. After the 6th administration of zoledronic acid and the introduction of solid oxide during 3 weeks, the blood velocity of rat's periodontal speeds up to 66%. If we will check only the bone tissue with mucous membrane, but if we find the registration of only bone tissue, we'll find that the blood velocity restores up to 90%. To sum up my speech, the method of combination of two Dopplers, it is not invisibility. It has a high speed and accuracy because we want to check to register the blood velocity only for about 5 or 6 minutes. The application of solid oxide in the way of the exposure of bisphosphonates improve the general condition of the microhemodynamics, restore the speed of blood flow of the mucous shell, mucous membrane, periosteum, and bone tissue. And studying the microcirculation in rat model allows using the data for differential diagnostics, for identifying correlation of effects some pharmacological drugs in each of histological layers from the mucous membrane to the bone together or separately. Thank you for your attention. Do you have any questions?
I have a question.
Yeah.
Thank you for your report. Thank you for your report. Can you tell us, please, what drugs among from solid oxide we can use to reduce the risk of drug-induced osteonecrosis?
Yeah, thank you. Thank you for your question. Yes, there are several analogs of solid oxide, of course, and some of them, all of them, should have an effect on the protective side of the blood vessels. For example, it is heparin, solid oxide, and some side of nitrous. Yes.
Can we use like well-known drugs as acetyl salicylic acid derivatives?
Yes, we can, but at first we should have in the pharmacological first of all, pharmacological brands should have some experiments on the yes, laboratory animals, and after this, for about 3 years, they should have models on the human. So yes, there are some analogies of this, but we as surgeons, as maxillofacial surgeons, we want to cure the human fast. In this way, we can write in the analysis, in the diseases, not main diseases, secondary diseases, some disorders in hemodynamics. And to this disease, we can introduce some interesting drugs such as aspirin, yeah, and others. So the main difficulty it is about the
About the
experiments.
work, yeah. Okay.
Yes, and the time, of course, the time. Mhm. Any questions? Thank you.
Really great scientific research. It's almost a doctor who made himself all these experiments. The second speaker is a young student. He is from the first course, and I want to invite Yefimov. I'm sorry, you haven't write your name. About dense invaginations, unpopular problem. Please introduce yourself.
Good afternoon. As you can understand, my surname is Yefimov, but my name is Konstantin, and today I would like to give a short talk about one very unusual and not very popular problem. Dense investigators. As we know, in the modern world, the variety of dental problems is extremely huge. Some of problems are really popular between almost all people of different ages from different countries, but there is a group of problems which is really rare, and a great example of such problem is dense investigators. But what does this term mean? It's trouble or anomaly, if you want, of the dense formation of the embryologic region. If we are talking about the radiographic examination, you will see something like a small structure. Just like there. The small structure looks like a small tooth inside the pulp of another one. That's why another name of the dense investigators is dense indenter. To my mind, it's really important to mention that according to the doctors Howells and Bloch, this trouble can occur in any teeth of any dentition. Milk teeth or permanent, it doesn't matter. Moreover, in 1957 was created a special classification of such problem. There are 3 classes of it, and the features of each class you can see on the screen right now. I do strongly support the idea that the only way to fully understand the illness is to show the real example of it. That's why just a few words about the real medical case, about the small Indian girl who several years ago visited the medical center in India and described the swelling in the upper right front of the jaw. After this, the dentist decided to examine her oral cavity, and during this examination he found a great dip on the upper right lateral incisor, and also he saw the slight decolorization of the crown. That's why he decided to use the pre-operate radiograph. This showed that the patient had two dance investigators of the third class, we remember several slides ago. As I could understand, it was a real surprise for the dentist, because it was a great deal and very difficult situation because of many reasons, but firstly because the apical area of of one canal was difficult to treat conventionally, but fortunately the results of the blood test of the patient was really great, and that's why the team of the dentist had a chance to begin the treatment immediately. I suppose that we do not have enough time for the whole course of treatment. That's why just a few words. A full thickness mucoperial steel flap was reflected, and fenestration on the fenestration on the cortical plate was noted at the level of the periodicular lesion. On these slides you can also see this trouble, and there you can see the features of the treatment. I suppose that it's important to say that it was really successful, because just after 1.5 months the patient had no symptoms of the disease, and just after the 6th month she could fully forget about the trouble. Of course, you can ask me why I decided to choose such topic. The answer is really simple. To my mind, it's a really unique situation when we have a medical disease, and that's why we have some questions. For example, how does it appear? How can we diagnose this? And so on and so on. But we do not have answer for these questions, because many scientists quarrel about the real reason of the appearance of such problem, because some of them believe that the irregular form of the crown can cause it. Others are sure that the trauma during the childhood period. But the correct answer we couldn't find. So at the end of my speech, I want to say that the treatment of such problem can be really dangerous. What does it mean? Because the surgical movement can be dangerous for the closed teeth and also for the gingiva as well. And if we are talking about the trouble with the milk teeth, it can cause the problem with the future dentition. That's why I believe that the only way to protect yourself is to check the health of your oral cavity every day, and because the health of the oral cavity is the health of the whole body. Thank you.
Thank you very much. Always it's very stressful to get a report in a big auditory, but it's a great job, and for us it's an opportunity one more time to show how we can speak, how we can report our knowledges. It's very important. The second speaker, young sisters from second course, yes? Christina and Karina Aganyan. Please welcome.
Good afternoon. Dear colleagues, dear members of jury, it's a great pleasure to be here today. Our names are Karina and Christina Ganyan. We are second year students of Faculty of Medicine. And today we'd like to give a small talk and present a report made on maxillary sinusitis of endodontic origin. So, the maxillary sinusitis of endodontic origin, it's a new term coined by the American Association of Endodontists in 2018. It's the rhinosinusitis developed secondary to the primary endodontic infection, endodontic disease, but it doesn't really look like one. That's why people go not to the dentist, but to the medical doctors. And the medical doctors probably don't recognize the disease. That's why they prescribe the wrong treatment. And that's a really big problem that occurs every day. Let's move to the etiology. As you can see on the slide, the maxillary molar roots and the sinus has a very close, I'd say intimate, anatomical relationship. And that provides a pathway for infection to move upwards. So firstly, it's in the pulpal infection, then it moves to the periapical tissues, and only then up to the sinus. Also very interesting that the very reason for this infection to be developed is that canals are left untreated, and the root canal failure occurs. Also, the interesting thing is that thickening of the soft tissue barrier, named as mucositis, is present. The thickening provides closure of osteometal complex and the swelling, inflammation, and the accumulation of purulence. And as you can understand, it's the perfect conditions for anaerobic infection. We shall say that this infection is polymicrobial, meaning there are both aerobes and anaerobes, but of course the dominance of anaerobes is present. As you can see on the diagram, the first molar tooth is mostly associated with the maxillary sinusitis of endodontic origin, and of course there are some reasons for it. Indeed, first of all, first molar tooth erupts earlier than the second molar tooth, and that's why it is more susceptible to carious dental regions. Besides, first molar tooth has that anoic mesiobrachial second root canal, which is called for short MB2 canal, and it is very small and thin, and it's also present in 92% of the cases, but yet general dentists often miss it, and that's very often the cause of the infection. Now let's talk about diagnosis. Unfortunately for diagnosing clinicians, the symptoms of MSCR do not differ much from those of non-odontogenic sinusitis. They include sinonasal symptoms such as congestions, rhinorrhea, postnasal drip, facial pain, also foul odor, and unfortunately they are typical unilateral, and these symptoms are also subclinical. Besides, dental symptoms are often not present. It means that there is no percussion tenderness, no intraoral swelling, and also no thermal pain. Cone beam computer tomography is a golden standard radiographic exam for evaluating of paranasal sinuses. And there are two unique findings. First of all, there is periapical osteoperiosteitis, which is an expansion and inflammatory reaction of the sinus for periosteum caused by apical periodontitis. It causes an upward displacement of the sinus or periosteum into the sinus, and inflammatory mediators induce the periosteal reaction, and that's why what we call a hard tissue dome or halo is formed over infected root apex, as you can see here on these radiographic images. The second unique finding is what they call periapical mucositis. This is an edema of the maxillary sinus mucosa caused by apical periodontitis. It is characterized by thickening of the sinus form mucosal tissues, and it differs much both in size and in thickness, and eventually this could lead to sinus obstruction, which is a complete occlusion of maxillary sinus. This is very well seen on radiographic images, yes, but it's very difficult to recognize it as having dental etiology. So unilateral sinus obstruction, especially if recurrent or associated with patent infundibulum, is a strong indicator for odontogenic sinusitis. However, clinical examination is essential. It includes thermal testing, electric pulp vitality testing, also percussion, palpation, periodontal probing, and mobility tests. Clinicians should carefully examine for untreated or suboptimally filled canals, inadequate core restorations, weakened core restorations, to find out an endodontic reason or endodontic failure, or probably a bacterial source for the infection. And now let's move to the treatment. There are two main goals that we should follow while treating the patients with maxillary sinusitis of endodontic origin.
First is elimination of infection, and second is restoration of ventilation drainage. While treating the patient, we should remember one very important thing, is that we need to understand the etiology of disease. The otorhinolaryngologist probably can't make the thing and can't make the treatment because the reason is the endodontic infection. That's why there are some treatment options, such as non-surgical root canal therapy, periodical surgery when indicated, intentional implantation, and the extraction of the infected tooth. But the thing is that some data says that extraction of the infected tooth sometimes should be avoided because there is a big risk of oral-antral fistula development. Also, we should say that American Association of Endodontists says that antibiotic treatment as a definitive solution may be ineffective. Because first of all, the dental clinician may probably not even understand that it's a sinusitis because you can't understand the patterns of inflammation when they are gone. And second of all, the antibiotics can bring and build up the new resistant biome. Of course, in some extra cases, the surgical intervention is needed. And when it happens, we shall have some options such as Kalbe-Luke surgery, functional endoscopic sinus surgery, and a new procedure, balloon sinuplasty. Now I would like to show you a technique.
So, as my sister said, balloon sinuplasty procedure is really new, and it was introduced in the year of 2005. And first, a person who does the procedure should position the sinus guard catheter into a nasal cavity, then advance the sinus illumination system into the sinus, so that afterwards he would be able to use the sinus illumination system to confirm the sinus access by transcutaneous illumination. Once it is done, the surgeon should inflate the sinus catheter across the sinus ostium so that afterwards he would be able to irrigate the sinus. Once it is done, the sinus is cleaned. So the surgery is performed and we have reached our goal. Now that the sinuses are clear, let's move further, but I want you to understand that sinus surgery should be performed in some extra cases. The first thing that we shall do is to treat the endodontic reason. So let us tell you about one study which was made by Tamamatsu. He evaluated 39 patients who underwent endodontic treatment by extraction, and so 20 patients showed full resolution of sinus obstruction, while 19 required an adjunctive sinus surgery. And this study confirms the position of American Association of Endodontists of managing MSCO by first treating the primary endodontic infection, followed by clinical and radiological assessment, and only then go to sinus surgical procedures only in recalcitrant cases. So the key is treating the source, and this cartoon actually drives this point home nicely. If you have a basement and if you want to cope up with the flood in the basement, you should not destroy the walls of the basement, you should just patch up the leaking faucet. And here we can see the interaction between ENT and the patient. And ENT says, we've tried conservative medical therapy, it didn't help. Now let's go on and move on to a surgical intervention. And endodontist says, I know I wasn't consulted, but maybe shutting off the leaking tooth is a more elegant solution. So we believe that treating the source of the inflammation rather than manifestation of it is an effective thing. To conclude, we'd like to say that maxillary sinusitis of endodontic origin is frequently overlooked by general dentists and also sometimes by ENTs. And we believe that there should be an open referral relationship between dentists, endodontists, and ENT specialists to provide our patients with a quality treatment, not just a treatment, but a quality treatment. For, after all, 40.6% of all cases of sinusitis are odontogenic in nature.
Thank you for your attention, and we'd like to wish all of you successful treatment with patients with maxillary sinusitis of endodontic origin. Thank you. Any questions? No.
Thank you. Maybe our specialists from sinuses have a question? Okay. Okay, thank you.
Thank you.
We have a few interesting topics about treatment of sinusitis, and the second speaker will be Karpyshenko Yana Sergeyevna. I'm sorry.
one more sinusitis. Hello, dear colleagues. My name is Karpyshenko Helen, and I present you my topic, image guidance in cases of maxillary sinus foreign bodies. The problem of maxillary sinus foreign bodies is very common. In most cases, it's a result of medical procedures in dental area. And surgical removal of foreign bodies is indicated to prevent secondary sinusitis and fungus ball formation. Historically, the surgery on the maxillary sinus was made transoral. Nowadays, surgeons can choose different approaches and different kinds of anesthesia. So maxillary sinus foreign bodies vary in their origin and kinds. They can be presented by filling material, implants, parts of wood, glass, metal, etc., etc., etc. They can be fixed in the bone, in the mucosa, in the fungus ball, or in some cysts, or free-lying. And surgeon can remove them by different ways: transnasal, transoral, or via wound canal. And computer tomography has become a very important method of diagnostic and one of the most informative and modern methods of X-ray for the patients with maxillofacial region diseases and ENT diseases. Nowadays we have two mostly used kinds of computer tomography: cone beam and multispiral. And the surgery on the maxillary sinus without preoperative computer tomography is not safe and it's not safe and expedient. And both types of this computer tomography can be used in navigation systems. So what's image-guided surgery? Image-guided surgery means surgical usage of tracked surgical instruments in conjunction with preoperative or intraoperative images in order to guide their procedure. And the navigation system provides the surgeon the true position of the instrument during the operation. The working principle of any kind of navigation system is similar with the principle of GPS navigator. And nowadays we have two kinds of navigation systems: the electromagnetic based on the electromagnetic field. This one we have at our department. And another one is based on the infrared radiation. So in an example, the patient appealed for the medical treatment. He was referred to our university by his dentist. During the implantation of dental implant, it reached the maxillary sinus, and the patient marked a discomfort in his right maxillary sinus. On the preoperative CT, the foreign body was located at the maxillary sinus floor. And the CT data, cone beam CT data, was loaded into the navigation system, and the patient was registered in the system. The computer combined the pre-operative CT data with the position of the patient on the table, and the patient was treated under the local anesthesia endoscopically via inferior nasal meatus. Endoscopes of 0 and 30 degrees of view were used, and the foreign body was disclosed and removed from the maxillary sinus. The operation window was closed, and the bleeding was minimal. Post-operative tamponade was not necessary at all, and the patient released from the hospital at the same day. Totally 169 patients with the maxillary sinus foreign bodies were treated at the ENT department under the control of the navigation system. Both types of computed tomography were used. About 70% was cone beam computed tomography. And in conclusion, the problem of foreign bodies is very common because of the development of dental treatment mostly. The trajectory of the surgical approach to the maxillary sinus can be formed by the navigation system, so it decreases the time of searching the foreign body in the sinus. And always the surgery under the additional control is more safe for the patient. Also, the navigation system helps trainees to realize the 3D anatomy of human. And both types of computed tomography can be used in it. And the surgical approach to the maxillary sinus via inferior nasal meatus with a temporary window formation is one of the most adequate, safe, and non-invasive for searching and removal of foreign bodies. Any additional surgical approach usually is not necessary. Thank you for your attention. Any questions? I think we have time.
It was thank you. The second report about the prospects of using polymeric scaffolds in oral and maxillofacial surgery from Ivanova Elizaveta, also the doctor from the Department of Maxillofacial Surgery.
Welcome, dear colleagues, and a little bit more sinusites. Dear colleagues, let me represent my report on the prospect of using polymeric material, polymeric scaffold in oral and maxillofacial surgery. The purpose of our research is to evaluate a possibility using of polymeric construction on the basis of chitosan in experimental model of maxillary sinusites. Perforative sinusites is most common form of odontogenic sinusites. Closing of oral communication is important to avoid of bacterial infection, impaired healing, and chronic sinusitis. Standard treatment scheme include antimicrobial therapy, sinus surgery, and closure of oral communication. There are many techniques to prevent of chronic presence of oral communication, such as buccal flap, palatal rotation flap, and buccal fat pad. The closure of the communication with autologous bone graft substitutes is alternative to flap-based techniques. But traditional methods have a number of disadvantages that you can see that in picture. Therefore, in case of oral communication, it's needed to use the material which meets their following characteristic. May be used in inflammation, separates of maxillary sinus membrane and oral cavity mucus, and can transfer cells and drug and promote bone regeneration. According to the literature, chitosan is some of the most studied natural polymeric material which meets the specified characteristics. We conduct experimental work and studies a possibility of using polymeric chitosan matrix in defect of the rabbit's upper jaw. First, we studied structure of rabbit's upper jaw and main anatomical feature of maxillary sinus. Experimental model of maxillary sinusitis was created after molar tooth extraction. The result was evaluated on the CT scan of upper jaw. Then the 9 rabbits were divided into 2 groups, control and study group. Rabbits of the study group were prepared circular bony bone window on left sinus membrane bony wall 5 millimeters. Perforation was done at the center of the exposed membrane. The left sinus membrane window was repaired by chitosan membrane fixed with a mini screw. Finally, the wound was closed and sutured. The rabbits of the control group were prepared bony bone window at the angle of the mandible and repaired by chitosan membrane fixed with suture with additional bone window. The wound was sutured in layers. 9 rabbits were sacrificed after 4, 8, and 12 weeks after operation. Then we take the material for histological observation. A month after the surgery, the chitosan matrix is formed connective tissue capsule around the material. Chitosan matrix is without the effect of resorption. Similar processes were observed on the upper jaw. At high magnification, there are inclusion of fibrin in chitosan pores. 2 months after the surgery, full-blooded circulatory vessels and cellular fibroblasts are determined in the capsule. 3 months after surgery, around the implant is determined sharply thinned connective tissue capsule. There are active osteoblasts on the surface of the bone. In peripheral cells of the matrix, there are sprouts of loose fibrous connective tissue. We conduct study in vitro. Antiseptic was introduced into the chitosan matrix, chlorhexidine. According to the result of microbiological examination, it's noted the absence of positive growth of colonies Staphylococcus aureus during the week. Summarizing, we can say that the chitosan matrix doesn't have a negative effect on the tissue and bone and have a number of positive characteristics. Excuse me. Thus, it can be concluded the chitosan matrix is biocompatible and non-cytotoxic, has a high degree of porosity for migration of mesenchymal stem cells into it, and promote recovery of the lost bone fragment and prevent formation of commissure between maxillary sinus and oral cavity mucose. Thank you for your attention.
Today we have a very shy auditory. Nobody wants to ask something. It's okay, it's normal.
Everything is clear.
Yes, everything is clear. It's a new aspect of treatment of sinusitis, and we going another interesting topic about very interesting clinical case report, and Nadira Kasimova will tell us about it.
Dear judges, colleagues, my name is Nadira Kasimova. I'm the first-year resident student, and the theme of my report is sinus histiocytosis with a massive lymphadenopathy, Rosey-Dorfman disease clinical case report. This work is devoted to This work is devoted to a clinical case report of a rare systematic disorder, Rossi-Dorfman disease, and the aim of the work is clinical case report of cutaneous form of Rossi-Dorfman disease. The analysis of scientific literature helped us to reveal different features from different forms of this disorder and diagnostics of SHML with specific diseases of maxillofacial area with different ways of treatments and the percent of their success. Also, the tactics of maintaining the patients with the SHML skin form were created. So, Rossi-Dorfman disease, also known as sinus histiocytosis with massive lymphadenopathy, is a rare disorder of unknown cause that is characterized by abundant histiocytes in the lymph nodes, and it's characterized by benign disease course but can be followed by as oncological as reactive processes. In 1969, two pathologists, Juan Rossi and Ronald Dorfman, reported about distinction of histotic disorder of young black women and called it sinus histiocytosis with massive lymphadenopathy, and later it was renamed into Rossi-Dorfman disease. Now let me show you some science evidence-based information about this topic and disorder. So in 2017, Cohen and others reported that the SHML frequently affects the children and young adults and presents and characterized by the presence of large histiocytosis with the incidence S100, CD14, CD68, and imperiopalasis. This is actually very important, so you should remember. So Han and others said that the painless lymphadenopathy is the most widespread manifestation, which includes cervical region in 90% of the cases that you can see on the slide, and other sites are inguinal actually and mediastinal lymph nodes. Posony and others from the numerous literature reviews found different treatment ways of the SHML, and they discovered 80 cases published in the period during the from 1969 to 2000, so you can understand that it's not that much, so the disorder is very rare. So the spontaneous permission of this disorder was observed in 32 of 40 cases. So the authors made the conclusion that the dynamic observation of this disorder and the observation of the patients can be appropriate option of the treatment. In the case of life-threatening compression, operation was necessary, and it was actually efficient in 8 of 9 cases. Radiation therapy was efficient in 3 of 90 patients, and chemotherapy was inefficient. So, clinical case report. Patient, 54 years old, had a skin lesion on the right buccal area, and from the anamnesis in September 2016, she has a consultation of the surgeon who made the preliminary diagnosis, and it was furuncle of the right buccal area, and it was drainage. And after the inefficient external therapy of GKS in 2016 of this December, she had a consultation in the dermatovenerology dentist clinic of our university, and she was hospitalized in First Pavlov State Medical University because of the unclear diagnosis. Objectively, you can see that the patient was in a satisfactory condition. During the hospitalization in December 2016, she had several tests, and all of them were negative or standard. So the results didn't show any pathologies and made the differential diagnostics being complicated. In May 2017, to avoid systematicity of the process, consultation of different clinicians that you can see on the slide was conducted to make the decision on further steps of maintaining this patient. So according to the consultation, she had several tests and several consultations of the different clinicians, and all of them didn't show any pathologies except of antibody levels, and they were 1 to 800, and we can talk about the chronic invasion connected with the work of the patient. She was working at the chemical factory. So and the toxicorosis was discovered. The toxicorosis is the clinical disease caused by the infection of toxicaris. This is the roundworms of the cats and the dogs, and the cutaneous form is very, very rare. All of these diseases that you can see on the slide, we were examining the patient and they were excluded. So diagnostically clinical case of this patient wasn't clear, and it was very, very hard. But in May 2017, morphological features of chronic productive inflammation without a certain nosological accessory were histologically found, and immunohistochemical studies revealed us a phenomenon of empyropalasis, which we were talking before. And morphological changes are characterized by proliferation of large polygonal histiocytes in their cytoplasm with the protein S100 and CD68, which I was talking before. They were discovered. So in May 2017, diagnosis was sinus histiocytosis with a massive lymphadenopathy, Rosey-Dorfman disease. So the results. After the examination of the results, clinician came to the conclusion: the surgical excision of skin lesion of the right buccal area, and in preoperative period, ultrasonic Doppler ultrasonography was done, as you can see on the slide. It was done for choosing the most aesthetic flap with a reliable blood supply. So it was submental flap. Here you can see the stages of the operation. The marking the flap is here, based on the submental vascular bundle. And here the 7 days follow-up. And after a year, in December 2018, she had the correction of the flap with reducing the volume of this flap of submental tissues, and the aesthetic and functional results with the compliance of the color of tissue and the surrounding tissues and the tissue of the flap was noted. The patient was in a satisfactory condition and was functionally and socially rehabilitated. Treatment of Rosey-Dorfman of this patient proceeded without recurrences. In conclusion, I'd like to say that for maintaining patients with the pathology, with this pathology and with Rosey-Dorfman disease, multidisciplinary approach of specialists, including dermatologists, pulmonologists, oncologists, and maxillofacial surgeons is necessary. Thank you for your attention. Do you have any questions? Yeah?
Thank you very much for your report. My question is the following. Were any drugs among from the topical glucocorticosteroids used during the treatment of this patient?
Yes. As I told you before, so she went to the surgeon who made the preliminary diagnosis and gave her these glucocorticosteroids, but the conservative treatment of these patients, I was showing you the studies and evidence-based information, and in this case, actually the conservative treatment wasn't efficient. Mm-hmm. So the better was to surgical excision with the flap. Yeah.
So what about antibiotics and something like this?
Yes, she was taking antimycosis and antibiotics because of the toxicaris. That's all.
Anti-allergics, of course.
Mm-hmm. I'd like another question.
Mm-hmm. Yep.
Thank you very much for your report. Nadia, could you please tell us, is there any symptoms, early symptoms for us, for surgeons, to take some strategical decisions what to do with these patients? Is there any early symptoms?
Earlier symptoms, you mean?
Not markers of the blood, but maybe some CT symptoms, maybe symptoms with the anatomy system.
Thank you for your question. I can answer for this question like like this. I was searching a lot of information on the PubMed and different reports, and actually there are only 90 reports about the cutaneous form of Rosalie Dorfman. So that was amazing that she came here, and we found this disease, so that we were making this report. And answering for your question, first, it's very rare. So I don't think that you will have this patient, or I will have. I think that was a luck. The second, I was reading one French report, and it was very, very interesting for me. I translated it into English, because in Russian I didn't understand it, but in English it was great. So they were talking about the the pathology of this disease. As I told you before, when I was starting the report, I told that it's unknown cause. But in 2018, it was a report about, they were discovering the families in Pakistan, and they had the specific gene, M687, that is responsible for this disease. And also it's responsible for diabetes type 2, also some bone diseases, with women who has osteoporosis. So this gene is responsible for the group of these diseases. So this sinus histiocytosis is there as well. So I think I would put this patient to the group of the risk. So if I was a surgeon, who is operating every day, I would just check, and I would think about such patients.
You will check the proteins, markers, and blood?
About the tests. About the test, I would check immunohistochemical studies, because it revealed the emperipolesis, and this is a process when the one organism, the site is going to the other, and it looks like a phagocytosis, but the end is that nobody dies, so everyone is alive. So this is emperipolesis in the simple words. So and I would check immunohistochemical things. Then I would check histologies. That we did in this report. This is the only way to find, the cutaneous form, because there are a lot of different ways. Also in this report that I told in the 2016, Define the Han said that in decreasing order of the frequency of this disease, the locations are like skin. Then less is nasal cavity, then accessory sinus of the nose, then orbit, then eyelid, then bone, then salivary glands, and after that central nerve system. So actually she was in the top. This is the most widespread side, the skin that she had.
Thank you for answering.
Thank you very much.
I think you can continue after our conference to discuss this topic. Thank you, Nadira. We have 3 last topics, and they will be very interesting for us. Please not leave us. The second speaker, Перекалина Anastasia, about another vision of treatment drug osteonecrosis.
So, dear jury members, dear colleagues, my name is Перекалина Anastasia, and I am a 4th-year student of the Faculty of Dentistry. It is a great pleasure for me to be here, and I would like to represent you the results of my research called Drug-Induced Osteonecrosis of the Jaw, Assessment of Localization, Detection of a Provoking Factor, and the Effectiveness of Treatment. Such diseases as oncology, osteoporosis, and drug addiction are widespread in the modern world, and it could be evidenced by statistics. So, for example, during the 12-17 in Russia were registered 541,000 cancer patients, 157,000 osteoporosis patients, and 800,000 drug addicts. Nitrogen bisphosphonates are inorganic pyrophosphates that decrease bone turnover, used to reduce bone pain, improve quality of life, and reduce or delay skeletal complications. Since their approval in the mid-1980s, BP have become the established treatment for disease of excess bone resorption, such as cancer-associated bone disease, metastatic lytic lesions, multiple myeloma, and osteoporosis. Denosumab, a receptor activator of nuclear factor kappa B ligand inhibitor, RUNCL inhibitor. The Food and Drug Administration approved it in 1210 for the prevention of skeletal-related events in patients with bone metastasis. Desomorphin is a synthetic morphine analog opioid. Illicitly produced desomorphin often contains large amounts of toxic substances such as codeine, red phosphorus, gasoline, acetone, and iodine. Injecting any such mixture can cause serious damage to the skin, blood vessels, bone, and muscles. Moreover, it can cause the osteonecrosis of the jaw. Despite clinical efficacy, high dose or long-term BP or denosumab exposure is associated with a rare but serious drug-related complications such as osteonecrosis of the jaw. It was defined by the International Task Force as presence of exposed bone in the maxillofacial region that does not heal within 8 weeks after identification, exposure to an anti-resorptive agent, no history of radiation therapy to the craniofacial region. Materials and methods. The present study includes 35 patients suffering from ONG who were treated at the Department of Oral and Maxillofacial Surgery between 1215 and 1219. We have examined follows variables: statistical characteristics, microbiological study, treatment factors, and clinical cases. Speaking about the results, a total of 35 patients fulfilling the clinical criteria of ONG was identified. Among them, 66% female and 34% male. The patients were divided into 4 groups depending on the associated disease and history of desomorphin intake. Firstly, malignancies, which make up 67%. Next, osteoporosis, 9%, and multiple myeloma and desomorphin, both at 12%. The table shows the results of statistical study for each group of patients. So, as we can see, OP, osteoporosis, is typical for women in 100 cases. Taking desomorphin is typical for men in 100 cases. Speaking about the localization of the lesion, mandibular lesions is dominant, 62%. Tooth extraction was registered as a risk factor in 66% cases. And after surgical treatment, 60% of the patients reapplied due to the redevelopment of the osteonecrosis of the jaws. According to the foreign studies, actinomyces colonies are frequently found in contact with necrotic bones in ONG lesions, supporting the possibility that bacteria could play a key role in the pathogenesis. There is evidence that the occurrence of ONG is significantly reduced by the treatment of the oral infection. ONG is a pathological condition occurring only in jaw bones, which have certain precise anatomical and microbiological features that predispose them to bacterial infection. Here are some photos of the bone tissue biopsy from the lesion, which we used for our microbiological research. Microbiological examination was performed in 4 patients receiving therapy with bisphosphonates or denosumab. So there is the table which shows us the microbial associations: Staphylococcus aureus, Streptococcus parasanguineus, Neisseria flava, Streptococcus pyogenes, Actinomyces aureus, Streptococcus epidermidis, and Staphylococcus capitis, and their resistance to antibiotics such as ceftriaxonum, linezolidum, clindamycinum, and amikacinum. ONG may remain asymptomatic for long periods, ranging from weeks to several months or even years. ONG typically manifests as painful and often infected areas of necrotic bone. Here are some clinical cases show us the clinical picture in the oral cavity. So there are some necrotic areas in the oral cavity and infected areas. All in all, we confirm the mutual relationship between the intake of drugs and the development of anti-osteoclastic associated osteonecrosis of the jaws. Mandible is more likely to be affected. Tooth extraction is a risk factor in development of ONG. Surgical treatment is not effective in 40% cases. Microbiological research helps us to choose right antibiotic drugs for treating patients with ONG. And we can prescribe the correct therapy to prevent its development and relapse by controlling oral infection. Thank you for your attention. Be glad to answer all your questions.
I have a question. Sorry. Thank you very much for your report. What methods were used for bacterial identification and for antimicrobial drug resistance identification?
It was the microscopia. So microbiologists from our university helped me to do this report. So it's the microscopy of the biopsy we have. We put it in a special liquor after the surgical treatment, and then we just identify the associations and their resistance to the antibiotics.
So it's just like morphological research?
Yeah.
And antibiotic resistance using disc methods?
Yes, disc methods. Yeah. Any questions? Yeah? Yeah, okay.
Thank you for the report. It was very interesting. I have a question about the statistical data.
Yeah.
According to what databases you have searched for about statistical data in the beginning slide of our country? Is there any databases in the internet?
Yeah, here are references, and we can see that it was like statistical research number 6 for 2017 year. It's the common statistic of Russian patients.
Thank you.
So that's all. Thank you.
We will wait you next year with a new statistics here. The second speaker, Dmitry Grachov, about application of botulinum toxin in maxillofacial area.
Good afternoon, dear Presidium, dear colleagues. Let me introduce you my topic. It's application of botulinum toxin A in patients with facial nerve palsy after operative treatment in the lateral facial region. Here on the slide you can see the statistical data of the Russian Cancer Research Center from the 2010. This statistic data, according to this statistic data, the salivary gland tumors account for 6% from all neoplasms of head and neck. And we have conducted a survey study of modern periodical literature on this topic in foreign sources, and we noticed that the data corresponds in principle with the data of Russian authors. The largest share is made up of benign tumors. It's account about 80%, and with the most frequent form is pleomorphic adenoma. Often, when the tumor is removed, the risk of a serious complication in the form of facial nerve paralysis increases. Since in the domestic literature sources the frequency of occurrence of this pathology is poorly described, we carried out an extensive research work on this topic, on findings of articles reflecting the surgical treatment of parotid salivary gland in the, to assess the state of problem in the leading medical universities around the world. And extrapolating this data from these sources, we stated a goal in form of improving the results of rehabilitation of patients with facial nerve palsy after surgery in the lateral facial region. Our work is included the treatment result of 106 patients with pathology of the lateral facial region who received treatment in our clinic maxillofacial surgery for the last 4 years. All obtained statistical data were processed with the help of modern statistical licensed computer programs and entered into the planning and accounting software for dispensary observation. Here is the patent on this program. According to the analysis, we found out that women prevailed among the other patients, among the men, and in all cases for preoperative control, we used methods of radiological and X-ray and neurophysiological control. They included the ultrasound, MRI diagnostics, helical computer tomography by indications, and electroneuromyography with immune component. And during the operations, we used intraoperative methods of control and visualization. Intraoperatively, as I said, we used intraoperatively in 84 clinical cases, we used the neuromonitoring assistance to visualize for gentle and precise allocation of the facial nerve course. If the tumor was located deeply in 4 cases, we used electromagnetic navigation to find out where the stylomastate foramen is located, and according to this, we find out the exit of the facial nerve from the bone, and continuously used the neuromonitoring to follow this nerve. And yes, in some situations, even if with the conducting the extirpation of parotid salivary gland, the use of intraoperative neuromonitoring allowed us to preserve the facial nerve from injury, and thus making such results that you can see on the slide. After a year after operation, this patient had a completely closure of the eye and normal smile, and this is because of the perioperative and intraoperative control. But there is a situation when there are situations, especially when we speak about extirpation of parotid salivary gland, when we are not able to preserve the nerve, especially if it lies into the tumor process. And because of this, we need to dissect this nerve and simultaneously perform the neuroplasty. And we have 16 patients with this disease, with this pathology after operation, with the post-operative paralysis of facial nerve. As you know, facial palsy symptoms consist of facial asymmetry, of problems with eyelids, inflammation problems with eyes, difficulty with eating, drinking, conversational difficulties, and in the long term, appearance of synkinesis and muscle spasms. And for this reason, the botulinum toxin type A is used. Here you can see the example of the patient Che, who had been performed the operation, extirpation of parotid salivary gland 20 years ago. Here are muscle asymmetry, asymmetrical smile, difficulty in real life. She had difficulty in speaking, and she hadn't been done botulinum therapy. So the aim of the botulinum toxin therapy is so there's some problem, small problem. Okay. So the aims of botulinum therapy is decreasing of the facial muscle hypertonus that occurring on the healthy side when the pathological side is non-functioning. In prevention of pulling the face on the healthy side with these problems, it's aimed on facial symmetrization and reducing the frequency of synkinesis and contractions in a long-term period. Here you can see the doses of botulinum neuron toxin that were taken by Russian Dermatological Consensus in 2014. U means units, it's equal milliliters, and on the right column you can see our doses, average doses for patient. In all 16 patients we used botulinum toxin, and this is, and as you can see, they are smaller than the doses required for this type. It can tell that we can use it more than just required, and it helps us to prevent overdose complications and immunological resistance. Here are the clinical case of patient P, 40 years old. She admitted to the clinic of maxillofacial surgery in 2016, and you can see the appearance of her in the slide. The diagnosis was stated as a recurrence of the right palatal salivary gland tumor, lymphadenopathy of the right submandibular region, metastasis under the question. Here are also the ultrasound image of parotid salivary gland and facial nerve. The surgical stage was concerning the extirpation of right parotid salivary gland with the dissection of the nerve and neuroplasty, and with the right upper cervical lymphadenectomy. In the post-operative period, you can see this is the 3rd month after operation. There is a 5-stage according to the House-Brackman grade. She can't smile, she can't close her eyes, she have difficulty with eating, can't pull her mouth, her lips, and we used the botulinum neurotoxin, administration of botulinum toxin type A. On the 1st stage, we corrected the hypertonus on the unaffected side to make it possible to have a symmetry between paralyzed side and normal side. And on the second stage, we used also botulinum toxin in more higher doses to correct hyperkinetic faults on the healthy and paralyzed side to make it possible to for face to look symmetrically true. And here are the mimic after double administration of botulinum neuron toxin type A after 15 months of administration. The 5 grades decreased to the 2nd grade. And also she was done the full face method of botulinum administration just for aesthetic symmetry, because on the 2nd stage all functioning like mouth functioning, like eating functioning was corrected. And here are some, this is the results of comprehensive functional and aesthetic rehabilitation of patient, and after 1.5 years. And in conclusion, I would like to say that carrying out bone therapy, botulinum therapy, contributes to make a balance between muscle antagonists and synergists to improve the degree of facial symmetry, to reduce the pathological synkinesis activity in long term, to reduce mimic contractures, to reduce patient stress, and what is necessary to restore chewing and speech function. Thank you for your attention. Do you have any questions? Yes.
Tell me please, are there any alternatives to botulinum toxin or some alternative therapies to this condition?
Of course, first of all, in this condition, when the patient is suffer from the facial nerve palsy, is neuroplasty. It can be the primary neuroplasty that can be done during the operation, or secondary when the facial palsy have been for months, for 2 months, until 2 years, by the nerve plasty. If there is more than 2 years, it can be possible to choose muscle plastic from the muscle gracilis or another muscle like this, and to restore the mimics. It can be like artificial mimic, but it will be. Speaking of medical therapy, there is a lot of therapy like vitamins, type B, chirurgotherapy, kinesiotaping, yes, and some kind of this. But botulinum toxin is unique because it allows to make the face make the healthy side of the face looks like the paralyzed, and then to exercise the paralyzed face in future to make it symmetric. There are a lot of types of botulinum toxins, but for example, we have here xiamin. But really, I suppose it's a unique one.
Thank you.
Any questions? Thank you.
And the last topic, but very interesting, will tell us Alexander Kudrevich about evaluating the level of implant integration using immediate load method.
Dear judges, colleagues, my name is Alexander Kudrevich, and now you will hear about evaluating the level of implant osteointegration using immediate load method. So, implantation is a really widespread operation nowadays, and we want to achieve the best results. So, osteointegration and bone loss are the most important factors here. So for achieving the best results, we have different load protocols such as immediate loading, early loading, and conventional loading. Immediate loading is the loading when you load implant no more than 1 week. The early loading is load between 1 week and 2 months, and the conventional loading is loading after 4 months after implantation. So conventional loading is the most widespread in Russian Federation. Also we have other clinical success factors such as general health, operation area, bone quality and quantity, acute infection, primary stability of implants, systematic disease, immunodeficiencies, head and neck radiotherapy, alcohol or drug abuse, pregnancy, bruxism, and smoking habits. So we can't begin our cure without computed tomography. Computed tomography help us with evaluating the bone stiffness. So as you know, there are 4 types of bone stiffness. The first one is 100% compact bone. The second one is 50% compact, 50% spongy bone. The third type is 75% compact bone, and 25% is spongy bone. And the fourth type is fully spongy bone. So depending on this, we will have different healing time, and as far as you can see, the D1 is the shortest and the D4 is the longest. So the stiffer bone is, the shorter healing period will be. Also, the visiting intervals will be different. For stiffer bone, they will be shorter, and for spongy bone, they will be much bigger, as you see. So, also we should take into the account bone resorption. If bone resorpted a lot, the implant will have a different angle, and the more angle is, the less occlusal surface will temporary crown have. For evaluating the stability of implant, we can use such devices as OSTEL and Perotest M. The OSTEL is a device that measures the resonate frequency of implant, and Perotest M is measuring the time of contact between the device surface and the implant. So after operation, we should take into account such things as torque of the implant. It must be from 30 to 40 nanometers. We should also take the micro movements of implant. It must be between 50 and 150. So if it's more, we shouldn't lower the implant, because fibrosing encapsulation will start. Also, we should place implant from 1 to 2 millimeters subcrystal to avoid bone resorption, and also for best stability. The length of implant must be more than 30 millimeters, otherwise it won't be stable too. And in the final, we should take into account the angle of implant, so the vector of forces must be common to the vector of implant. And if we have several implants, they must be connected into one bridge. In the conclusion, I want to say that implant survival was 98% and 99% in immediate loading and control group. In the immediate loading, we had cortical bone growth, and using immediate progressive load method improved with bone stiffness. And tubercles start to orientate according to the force vectors around the implants. Do you have any questions? Or that's all? Okay, thank you.
Thank you very much. Okay, we finish. Listen our speakers, and now we have a time. Our jury will discuss who will be the winners. You know, we try to be honest and make you. Everybody was very good, very professional. Your topics very different, and everyone has a different level of their language, of their residence. But for everyone is the little way to grow up, to become better, to become more professional in your future in dentistry. And I will ask at the last make a photo together, and I hope our jury say something for us at the end of conference. ходим, сделаем в общем фото, и раз мы, вот кто-то уже уходит, пожалуйста, вот, ну не уходите, у нас же только еще всего в конце есть. Ну. Давайте сделаем фотографию, а я пока посчитаю, и мы узнаем, кто же победитель.
Интересно, фотографируй с тобой.
О, сейчас будут фотографировать. Мы попросим Герман. А мы попросим наших любимых студентов, которые досидели до конца.
Давайте я сфотографирую.
Самый большой молодцы,
Понял шутку? Advanced students. My students. Это тоже my students.
Или мальчиков надо. По традиции.
Все готовы?
Мы красивые получились. А то.
Надеюсь, в следующем году
Я вот в любом случае себя выложу, я дома еще отправлю. Так что ищите в соцсетях.
я понял.
Дополнительно.
Один раз мы это сделали.
Сейчас еще заканчиваем.
Но это какие-то маршруты там
А вы хотите, чтобы я речь слышал?
Не смотрю по самому большому, хотя их одинаково. И большой, это вот большой, не принимайте внимания, это не специалист, это так, это нянька-мамка писала.
Мне больше всего понравилось, совокупно, потому что я не знаю, это сложно оценивать там научную и практическую значимость, но тем более А так вот совокупно по выступлению, презентации и так далее, мне очень понравился как Попов выступил. И сейчас скажу, кто еще. И Карпиченко, наверное, да. Но я с ним вообще давно знаком, но в этот раз у меня было такое очень практическое выступление.
Фамилия, в принципе, одинаковые. Здравствуй, красивого, всех
Нет, не Синявский, тоже тут кирпичный.
А здесь автор уже написал, что он предполагает. Нет, это я только что сделала. Ничего, не было. Хорошо. Давайте это отдельно при зрительских демонстрациях. Нет, от меня, от лично от меня. Девочка, все. То есть специально не если вы
Тогда вот вы выберите, кто вам еще понравился. Тогда давайте на
кто у нас основные?
Основные, проведения. Да, скорее всего.
Давай, согласна. Хотите вы на деле за совершенно английский, потому что она в прошлый раз не только не знаю, она выступает, английский сложно не получить первое место.
Попов мне больше всего вообще понравился совокупного полностью.
В общем, скажите, да, не говорю, в любом случае у меня есть еще одно свободное, так что выберите
Дадим это 100% один из призов, потому что она больше всего отвечала на вопросы.
Да, вы уже сами.
Как у вас на как я понял, у вас вторая профессия важная.
Thank the audience for the patience and progress.
Yes.
Well, he was greatly impressed by your knowledge.
Hello everyone. I'd like to thank everyone, each one of you for presenting such incredible presentations. I remember myself also presenting a few years back, also cases, scientific stuff. And I remember that none of the presenters had such an amazing level of English, of animations, photos, and so on. And also, I'm very thankful for your really great, inspirational, and inspirational and very emotional presentations. So we are ready to announce our results, right?
Yes. Thank you. It was very hard choice because everyone do their best. The third place goes to very talented doctor from our native department, Permission Elena. here. The second place for another beautiful student, we hope you will have more great research and come back the next year and the next year and till the end of your postgraduate education. Перекалина Анастасия. And the first place goes the doctor who has best English. She answers the most questions and she make a very interesting report about very rare disease. Надира Касимова.
Alright, can I please say a few words?
Of course.
I was really amazed with all your reports. The level is very high, the English is perfect, presentations are fantastic, and it is really impossible to find the best student. That's why you remember the fairy tale about Sleeping Beauty. You remember this fairy that was standing behind the corner, and when all the presents were already given, she still kept her presents. And I would like to be such a fairy. I have small presents from my side, from side of company Stormos, and first of all, I would like to invite here the person who made today his first report. I remember that when I was a student, I made my first report when I was a student of the first grade. And I know that it is very difficult to be the youngest in the audience. So please, Yefimov, Konstantin. The great guy who made his first report today. And I also would like to invite here the most interesting lecturers. All lecturers, girls, were beautiful. But when you see two beautiful girls at the same time, it's fantastic. Please come here. Karina and Christina, I'm sorry, I have only one present, but I think you will share. And also I would like to invite here Bogdan. He was speaking so quickly, and I know the topic of SAC, but actually I was always thinking how he managed to translate it in English. It's incredible, absolutely. And also, as soon you're grown-ups, okay, but still you're a little bit children. I have some very childish present with the president of Childish Conference. Thank you.
You can take your certificate. I wish you good luck and see you next year. Thank you for your time.
Конечно, вот этот вот что-то не отлажено было, потому что вот я расслышала не дождались. Всего доброго.
Сейчас быстро.
Да, я тоже не думаю, что я буду долго делать. Сейчас мне как раз ведут за здоровье.
Да? Да, реванш.
Сказать заключительное слово.
Да.
Как флешку ничего не забыли?
Флешки нет, здесь это самое.
Можешь удалить свою презентацию, что мы больше.
Кстати, да.
Удаляй быстрее, вдруг там есть презентация. В следующем году будет такая же.
Конечно.
Я буду исправлять, только на другой экран.
Авторское право.
Сделай синий экран смерти компьютер. Так будет надежно.
Вот наше поколение.
Так, это закрываем.
Ух ты, мама.
Oh shit.
Big brother.
Oh shit.
Ты такой, Джоэль, хай-хай. What are you doing?